Okay, thank you for attending this Q&A session on technical research. So we spent 20 minutes together asking questions to 5 of the speakers who gave a talk in this session. Just remember, you can ask more questions through the chat, and we start by a question to Edwin Ageman from Frederick Padilla. Frederick is asking how to correlate this novel thermal dose performance metric to a biological outcome.
Yeah, that's something which we did not investigate, of course. This is just a first proposal. We did only one treatment so far with the MR-guided high-intensity focused ultrasound hypothermia algorithm from the Sonaleaf. But we think that especially we don't want to only have a technical evaluation of the algorithm and control hypothermia, but also have a kind of biological influence on that sense. So this is, of course, needs to be further studied, but this is really a good suggestion.
Okay. While I was looking at your presentation, I got a little bit confused on the motivation, on the definition of this new metric. How can you re-explain the benefit of this new metric compared to a conventional thermal dose?
So it's the problem with hypothermia is that you don't have a kind of dose limit like you have with ablation, right? The 240 EM is always set as a kind of way where you know for sure that you did your ablation successfully. What the hypothermia is always problematic because you have less thermal dose, but it also depends on how long you will do the treatment. And the thing is how to evaluate now a certain amount of dose you give to the patient fits to the optimal way you could give the patient the thermal dose. And that's why we divided maybe the ratio of it so that you compare something which is, you normalize it a certain way to the optimal case compared to what you did during the treatment.
Okay, it's like including in your calculation a target. I mean, and this is what you want to reach.
Exactly. So, and that means also that, for instance, you don't want even to have 42 degrees, for instance, the whole time, but it could also be 41, depending on your application. So it's not only about the time, but also on the temperature level you would like to reach and continue over a long time span.
Okay, thank you, Edwin. Let me check in the chat if we have more questions for you. If not, I will move to the next speaker, but if another one is coming later, I'll come back to you.
I'll ask one question.
Go ahead.
May I ask one question? And this is the system that you are going to use with MRI guidance. What kind of a ultrasound system that you are going to use, and what is the size of the beam characteristics?
So can you explain the question, ask the question again? What you mentioned was that it's MR-guided high-intensity focused ultrasound, and that's, yes, you need this because you need the temperature information and very accurately per pixel even. And it's also a unique opportunity because normally, let's say RF hypothermia treatments are done with temperature sensors. So you don't have even an overview of the whole heating area. They're changing now. I know that they also do MR-guided temperature mapping in that sense. But this is definitely key for evaluating the treatment.
Okay.
Yeah.
Okay. Let's move then to a question to Vera. I think Vera Koklova is next in the list. A question from Frank Wolfram. So he said, well, first said that your BH system is fascinating. I just summarized, but can the phase correction algorithm also detect obstacles such as cars, ribs, and switch off some elements?
We have not done specific experiments on that, but indeed it would be possible because the whole idea is to get a signal from the center, from the focus, and so when it goes to all array elements, if there is any obstacle on the way, there will be a shadow, so there will be less amplitude on the receiving elements. So it's possible to detect which one is in the shade, so we can stop it or modulate in the way we want. So it is possible. We have not yet tried. We were more interested in inhomogeneities of the soft tissue, but with ribs or other big mismatch of the impedance, it would be possible, of course.
Okay, thank you. Another question from Frederick Padilla. How did you modify the Verasonics V1 system to meet your power requirements?
Okay, we did several specific things. As far as we used very short pulses comparing to HIFU treatments, the average acoustic power was within the limits of the system. However, as far as we went to the very high peak power, we needed to maintain this power for at least 10 millisecond pulses. So we needed to add several capacitors, additional capacitors, to maintain this power. So technically, we made some modification to the software so that the system would permit us to go to this high peak power, and we needed more capacitors to maintain this peak power for pretty long time, but not very long.
Yeah, there is some hardware then modifications you should do too. He's also asking, what is the range of depths at which you can induce a lesion with such system?
Our aim are abdominal targets like liver, pancreas, or kidney. We aim for from 4 to 8, more from 4 to 6. So 4 to 6 seems very feasible.
You mean from the skin or from the transducer?
4 to 6 from the skin.
Okay. Naren, you want to ask one question? Otherwise,
can you talk a little bit more about your transducer design? Why particular shape?
This particular shape came, so we wanted to make irregular one, right? But we wanted to have a high filling factor. So this spiral array is pretty compact. It's about 60% filling factor, comparing to other spiral arrays that are about 40. On another hand, it is quasi-random, not regular, but it's more compact than another random arrays that we know. So to have it compact and to have high filling factor and to avoid regularity.
It's very impressive system. Congratulations.
Thank you, Naren. Yeah, that was a big effort.
Vera, I have one last personal. Oh, hold on. There is somebody else asking a question. Is the phase correction algorithm of your BH system for prefocal layers? Hold on. It's hard to also correct for obstacles such as cars. No, we asked this question already. Sorry.
Yeah, we did.
Repeat the question. Okay, my question then. I really like the fact that you use Doppler for evaluating the liquefaction of the tissues, and in your results you mentioned that it takes a speed of 30 centimeters per second in order to the tissue to be liquefied. So how did you come to this number?
It's not tissue. It's already liquid. So bubbles move with this high speed right after BH pulse. Then the speed is going down, and that's the maximum speed that we measured after 10 pulses when everything was actually a liquid. So that gives us, it's just measuring the velocity of bubbles right after BH pulse.
But it's like empirically, you've seen that once you reach the speed of 30 centimeters per second, you know that the tissue are liquefied in the hole?
Yeah, no, not really. Not really. It's actually liquefied even before that. On the other hand, it's a smaller volume. So when we go to with 10 pulses per point, it goes to this 30. With 5, it goes to some less amount. And we figure out that there is some connective tissue in the lesion. It would need more studies to actually go to the quantified dose, like 30 centimeters completely liquefied, or 30 centimeters per second, or 40 centimeters per second. But evidently, the velocity grows while tissue is liquefied and less debris is present in the lesion.
Okay, thank you, Vera. We move to the next speaker. This is Kizu Kim. And I have a question for you from Dennis Parker. Let me find it again. Well, he's just asking how close you are from doing in vivo experiments.
Not presented in this, not presented here. We had a healthy volunteer experiment without hitting. So we also found our multi-baseline approach can mitigate temperature errors in the liver. And also the spider sequence can take a good quality of images in the liver and kidneys. So we only did one volunteer experiment, but we need to have a more reproducible experiments with healthy volunteers.
Personally, I'd like to draw your attention on one thing in your presentation, and maybe Naren can correct me if I'm wrong. But for illustrating your application of HIFU under MR guidance and trying to find solutions for treating mobile organs, you use as an example prostate and treatment in the spinal cord. And do you think these targets moves a lot?
I think the prostate, that the motion is not like a liver or kidney, because that abdominal organs can shift it by the diaphragm. So it goes to the Z axis in the MRI scanner. So I think that motion is a little bit different. But
I agree with you. I think the examples you selected are probably not the best target you should aim at.
Yeah.
Okay, but liver is better for that. I have a question from Frederick Padilla again. What potential roadblocks do you foresee for clinical translation of the methods?
We can. Our goal is to make a transition clinical hyperthermia therapy. Actually, our main goal is to apply for hyperthermia, MR-guided focused ultrasound with hyperthermia. So our first goal is to develop a reconstruction pipeline for real-time and multi-slice, multi-baseline thermometry. So I think our developed technique can go to the clinical application to measure the temperature with the pre-reading. Okay,
so you think it's gonna be easy? You don't see technical difficulties for doing that? Oh, that's great then. Okay.
So one more thing. So the technical limitation is it may be from the cardiac motion, I think. So cardiac motion also can make a significant temperature errors in the. So we have to develop improve our algorithms to correct the kinds of motions, other kinds of motions. So currently we only can correct the respiratory motion.
Okay. I have another question for you, but we should move to next speakers and come back to you if we have time.
All right.
Okay. Next speaker who is around is Li-Fei Zhu, I think. What do we have? A question for you.
Can I ask him a question? Maybe. This is about the sonodynamics, right? And
I'm not sure. I don't have the title.
could you talk about? You have developed the bubbles.
No, Naren, because Mrs. Zong is not in the attendance. She's a person who is today.
Oh, okay.
So we are to the next speaker is Li-Fei Zhu. So Li-Fei, question from Frederick Padilla. Is the intent to induce thermal necrosis or to use hyperthermia to sensitize tumors to modalities such as radiotherapy or chemotherapy? So what do you want to do? Do you want to hit tissue for thermal ablation, or do you want to sensitize tumors for before radiotherapy or chemotherapy?
Yeah, the hyperthermia is designed to sensitize the tumors without damaging them, but we also found some tissue damage after we applied this technology. But we think that within that tumor area, it's also ideal to directly damage them, because that's happened in most of the cases. So the answer is so the tissue damage is also ideal and acceptable, and so in the future the tissue damage within the heating area should be expected if the 58 millimeter cell size is used.
I have a technical question regarding the presentation. Unfortunately, I cannot look at your slides and my notes, but in your methods, you define or select some threshold planes. Can you explain how you picked these planes?
So the Sonolip system has two planes for temperature measurement outside the heating room, including a near field, which is monitoring the tissue beyond within the target area and the skin, and the far field, which is a slice that's beyond the heating area. So I just picked those two slides that's used for tissue monitoring, and I use those two planes for limiting the temperature from overshoot, because those are two planes that's a system provided.
Okay. Thank you. Naren, you want to ask a question?
No, I think.
No?
May I ask one question for her?
Sure.
Lei-Fu, which kind of power did you use? Your acoustic power?
100 watts.
Okay, so you're a little bit, okay, that's moderate, because I was a little bit afraid because you heat probably too quickly that you get a temperature overshoot, because the algorithm needs next temperature map to decide if you reach the threshold, and it could be that you then get to too high temperatures that you get necrotic thermal necrosis at certain places.
Yeah, we look at the log file, and we found that the temperature actually was the maximum temperature overshoot was on warning, like every once in a while. So it did trigger the maximum temperature violation.
Yes, you can change that. So you can moderate them, put them at lower levels, even also for the max temperature. And also system time to have some temperature maps. Okay.
We have 1 minute closing, so I want to make sure we ask at least one question to Xiao Ying. Okay, Xiao Yu, you are performing harmonic motion imaging, averaging signal at 4 different frequencies, and you say that there is a benefit of doing that. Did you try averaging 4 times at the same frequency? Do you think this would improve your method?
So the reason why we wanted to try averaging across multiple frequencies is because we've found previously in our lab that different AM frequencies are able to increase contrast of different types of tissues better, as in like the different stiffnesses of tissues. And so the reason why we wanted to combine the different AM frequencies was so we can like combine those effects for different types of tissue types and for different tissue stiffnesses. So I don't think we would expect the same result if we just averaged the results from one single AM frequency.
Okay, thank you very much. That was very short. I'm sorry. I think we are about to to close the Zoom link. I have other questions for you, but maybe I'll send it to you in private. Are we done, Frederic? Can you confirm? All of you. Bye-bye.
Thanks.
Thank you, Cyril.
Thank you.
Bye-bye. Bye, Naren.